Hey everyone, Tony here. So in this video, I want to start a short series talking about medical necessity specific to Medicare. And I want to talk about how you can craft a hybrid model that allows you to provide the covered services that Medicare was intended to pay for, while treating and providing additional services that, while maybe beneficial, are not medically necessary and therefore eligible for cash pay. Self-pay services paid for by the beneficiary. So I always think stories are more interesting than facts and figures. Let's create a story around this. Now, this is not a real patient. This is a stock photography photo from Pexels, the website, but this would be a great case, right? So let's name him Jim. I have no idea what his name is. And let's pretend Jim loves golf. Jim has a prosthesis on the left, right? Left lower extremity. And Jim presents to your clinic with a referral in hand for physical therapy. Now, let's leave the prosthesis aside. Let's say Jim presents with right shoulder pain and neck pain. Okay, what can we do for Jim? So the first thing, obviously, you have to understand, and I'm going to give you guys some resources here, but when we look at the Medicare, let's look at this one, Medicare Benefit Policy Manual. If we scroll down to section 220 and we specifically come down to reasonable and necessary, these terms are super important for you to understand. And what I'm going to do is, while yes, rehabilitative therapy and maintenance therapy are covered services, there are certain criteria, right? And so just to give you a kind of a high level understanding, so the evaluation and the reeval, absolutely, I believe this is clearly stated. These are covered services because they require the skills of a therapist. I don't want you guys to use the terminology skilled care. I want you to try to get comfortable with saying, does this require the skills of a therapist? The evaluation totally does. Establishing treatment goals specific to the patient's disability totally requires the skills of a therapist. This is why we went to school. Designing a plan of care that addresses the patient's disorder, including establishment of procedures to obtain goals, definitely requires the skills of a therapist. Continued assessment and analysis during implementation of the services at regular intervals. That's important, regular intervals. Instruction leading to the establishment of compensatory skills. That's what therapists do. Selection of devices to replace or augment function. Training of family, patient, to augment rehabilitative treatment, right? So teaching support people how to help the individual. These are all clearly covered services under the Medicare Benefit Policy Manual. Okay, so let's go back. I forgot what we said we're going to call him. Let's call him Jim. And so Jim walks into my clinic and Jim says, I've got this right shoulder pain, neck pain. It's been bugging me for about 6 months. I can't get out, play golf as well as I want to. I saw my doctor. He said, come try therapy. Okay. I think for those of us, and this is an important distinction, for those of us who want to be in the world of self-pay, cash pay, and want to work with Medicare beneficiaries, that's a really common case. Now, absolutely, there's far more complex situations between neuro conditions and degenerative changes. Most of those clients, I'm not going to get into it. It's just a completely different case. This Jim is the guy that would walk into my clinic when I was in Florida. He would walk into my clinic in Ohio. So now, I do my evaluation because we've already determined that's a covered service. During my evaluation, I gather information, right? So Jim got dressed. He put those shorts on. He put that shirt on. He bathed himself. He groomed himself. He fed himself in the morning. Jim got into his car, drove into the clinic. Jim was capable of handling all of those things. Yeah, he had some shoulder pain and some neck pain, but he did all of that independently. Right? Jim's managing his finances, his checkbook. He's going to the store to buy what he needs to buy. He is living his life independently with his wife. He's retired, professional. He shows no cognitive deficit. So when I'm talking to Jim and we're doing stuff during the treatment and the eval, I teach him something, he's able to replicate it. He's able to understand and retain the information that I'm giving him. So these are all kind of criteria on my checklist to determine how much does he need one-on-one care with a physical therapist or an assistant supervised by a therapist versus how much of this can he do on his own, right? And so far, we're clearly painting a picture that, you know what, even though Jim has some impairment, he's doing pretty darn well. Okay, so now let's go into the medical complexity side of things. So let's say Jim, as most of my patients do, presents with type 2 diabetes. Jim presents with hypertension. He presents with maybe some pulmonary issues, maybe some breathing issues, right? The thing is, he's managing his diabetes with medication and physician follow-up. He's managing his hypertension and other cardiac risks with medication and physician follow-up. The same for any kind of respiratory condition, maybe COPD. He's managing it with a pulmonologist. So the important part when we get into, yes, he has these medical complexities, and that's why Jim requires a physical therapist to do his evaluation, create his plan of care, choose his goals with him, establish the program. But the reality is, Jim's conditions are very stable. There's not a lot of fluctuation. Now, if Jim was all over the board, he's not managing his blood pressure meds well, and some days Jim's presenting, 200 over 97, 98, obviously now we need a physical therapist involved in day-to-day care. But if Jim is managing these conditions and has been for years, he's pretty stable. There's not a lot of variability in this. So we've ruled out a lot of the lower level ADLs, IADLs, things like that. We've ruled out a lot of the medical complexities. So the reality is, in this scenario, now I do my orthopedic assessment. I rule out red flags, right? Everything makes sense. Nothing is out of the ordinary. I'm not thinking like my differentials, not thinking like, could this be cancer? Could this be a tumor? Does Jim need to go, to a specialist? No, he's got some arthritis. He's flared up a little bit. Most of the time in my clinic, now I don't usually talk about patient care very much, but I like to give you the idea. For me, these kinds of conditions, when there wasn't an acute injury that happened, there wasn't obvious tissue damage that's going on. Jim woke up 6 months ago. His neck and shoulder started to bug him. It got progressively worse and then it stabilized. That's a pretty typical situation. To me, that's more of a healing problem. That's more of a chemical problem. It's not really a mechanical problem. I could show you 1,000 patients just like Jim with the same postural differences, with the same tissue issues, and they don't have pain. Jim primarily is dealing with a pain issue right now. Say Jim has full range of motion, maybe it's limited due to pain. But the mechanical stuff for Jim at this point is really not that big of a deal, because 8 months ago, Jim had the same mechanical problems but no pain, right? So these are the things that I'm looking at when I'm thinking of a case like Jim. Okay, so we're at 8 minutes, almost 9 minutes. Let's wrap Jim's case up. So Jim comes in, I do the evaluation. I develop a plan of care. I teach Jim some therapeutic exercise. We do some therapeutic activity to put that exercise into function. Within a session, Jim pretty much has all the tools that Jim needs, at least logically, to do it on his own. He has the capacity to do it on his own. He has the mental and cognitive ability to do it on his own. So now Jim is presented really with 3 options. And let's pretend you're Jim. Okay, so Jim, that was awesome. The evaluation went great. You did all the exercises. You know what to do. Here are your options moving forward. I know Dr. Jones placed, on the referral 2 times a week for 6 weeks. The reality is, from Medicare guidelines, what you need to do beyond today isn't really paid for by Medicare. Because at this point, the stuff that I showed you, that's what needs to be done. But that's okay because today's session is covered at 100% between Medicare and your secondary. So that's awesome. You don't have anything to pay for today. After today, I want to give you two other options. Moving forward, you can do the stuff that I already showed you. If you're not sure about it or you feel like you need more resources, we have a video platform that you can log into online from home. I will prescribe the specific exercises I recommend you do for the next 4 to 6 weeks. The cost is $49 a month. You can cancel anytime. There's no commitment to it. It's really just for your benefit. But this will have the exercises with video clips and explanations. And then, of course, if you have questions for me, if you're part of that program, you can email me through the platform. You can message me. I can stay in touch with you like that. But ultimately, you do it on your own. The other option is if you want to come in here, most of my clients realize that if they don't have a place to go, they don't do the stuff they need to do. The stuff isn't complicated, but you're welcome to come in here. It's $100 a month membership. You'll come 2 to 3 times a week based on your availability. You'll have a scheduled appointment, and that's really where the value comes in. Because accountability is what makes you do what you need to do. So you'll have a scheduled appointment. You'll be expected to be here. But that being said, if you don't come, you're not, there's no cancellation fee or anything. I mean, you're the one that loses out. But there's always somebody on site, a PT or an assistant or somebody is here. So if you have questions, if you have concerns, if you're confused about something, we're always available to answer your questions. We're not working with you one-on-one because we have other patients, but you see the facility, it's 2,000 square feet. You're not going to get lost in here. And like I said, the main benefit is the accountability of knowing if you don't show up on Tuesday, we're going to be like, Jim, where were you? We missed you. Come on, get in here and do your program. So today's session was covered by Medicare. You're welcome to do the $50 a month and get the home programming with the videos, or you're welcome to come in here 2 to 3 days a week for $100 a month and do the programming on your own. And that's where I would leave it. So day one, Jim essentially really has 3 options. Do it by himself, do it with the video platform, come in the clinic and do it with us. That session, that one session, 1 hour with the therapist, pretty much, let's just average $150 reimbursement from Medicare. Let's say they do the $50 a month at home. Okay, so we hit $200 on the session if they do, which this is what most people are going to do. $100 1 month membership in the clinic, that's $250 reimbursement for that session, right? Now, moving forward from there, I determined manual therapy in Jim's case is not medically necessary. We're not dealing with an unstable fracture. We're not dealing with something that requires passive range of motion only. There is benefit. Now, this is an important distinction. There is benefit to providing manual therapy services, but it's not medically necessary. And the reality is, if Jim never got manual therapy but did the therapeutic exercise, I think the outcome would be comparable. And when we look at what's reasonable in terms of the cost of care and all the other stuff, I really think the difference would be negligible. Now, it feels good. It's beneficial. I'm not saying manual therapy doesn't have its place, but in this situation, Jim would be able to buy the manual therapy. Jim would be able to buy the dry needling. Jim would be able to buy the additional services that we think might help. The first thing looking at Jim that I'm thinking about is Jim might benefit from a nutritional program, right? Like when I look at Jim's anatomy, and I'm not talking about obesity, I'm just saying this to me looks like a tight, distended belly. When I look at his legs, when I look at his arms, and I look at the tightness through the stomach, through the abdomen, I think Jim might have some digestive issues. He might do great to look at working on, changing around what he's eating, seeing if we can work on his digestion. I'd be talking to Jim about constipation, diarrhea, gas, all of those kinds of things. That's not a covered service under Medicare when delivered by me. That could be a self-pay program. There are so many opportunities here, but what's most important for us to understand as clinicians is the role of Medicare, medical necessity, and what's reasonable. Medicare has its role. It serves a function. I absolutely, and I apply it back to my mom, my dad, my relatives, right? If Jim was my dad going to see a physical therapist, I would not want that physical therapist committing Medicare fraud, intentionally or not, to give my dad the services my dad would benefit from. I'd want that therapist providing the best possible service for what Medicare covers, and then giving my dad the option to buy additional service. Last thing, even from a golf performance, clearly he is a golfer. We can do covered service, eval, plan of care, develop that, and then do golf performance twice a week for a month, right? But that's a self-pay service. That's not a Medicare covered service. So guys, if you're still watching, I hope you are, the resources you're going to be looking for: the Medicare Benefit Policy Manual. Go down to page 175, read through this, get familiar with it, and then Medicare Claims Processing Manual, Chapter 30. Scroll down to, you definitely want to know the ABN scope, but Section 50.5 ABN triggering events. These are two absolute required readings, so you have an understanding of some of the Medicare guidelines. In the meantime, if you have more questions, if you want to discuss this further, please let me know. I'm going to post these resources in the video description. Subscribe to the channel, like the video, and if you can, share it with your peers, share it with others, because I think this is a conversation we need to start having more of. Guys, I'll catch you on the next video.